All right, everyone, welcome here tonight. Thank you for staying for the 15-hour marathon. We'll be concluding around midnight tonight, just joking. I'm going to give a quick talk, and then you're going to see some very expert injectors. What I'm going to be focusing on is some philosophy, but a lot of technique that's based or predicated on that philosophy. So, you know, I don't have any disclosures. All the textbooks and everything I've written is all go to charity, so I don't make any money on anything. So for me, what's revolutionized everything was the cannula for fat grafting. And subsequent to that, since October 2010, I've been using cannulas. And it's really shaped the way that I've done things, and it's allowed me to innovate a lot of things in the world of injectables that I just simply couldn't do with a needle. But it's only one technique, and you're going to see a lot of different injection methods tonight. So, of course, vascular preservation is important, and using the right cannula for that is critical. As you know, women put makeup on, so they get very close to their face, and they have a different perception of their face than what men do. And so I always talk about showing every patient beforehand the asymmetries and everything that they didn't notice beforehand that they will promptly ask you about thereafter. Probably once a week I get a patient upset at me for creating an asymmetry that pre-existed. So I show them the photo. That's the first thing I have my staff do, and they're usually reconciled to that they had it pre-existing. So volume is so critical, as you know, but what is volume? Volume really has to do with what I like to call halos and circles. And so I'm going to talk about that philosophical construct that hopefully can filter your worldview. So obviously it's a halo around the edge of the face. I'm very, very focused on the edge of the face, but it's also the halo or circle around the eyes and then around the mouth. And this is really, this is what I call a framing to the face. And so that's important. Like a chin implant frames the lower face, a hair transplant frames the upper face, a facelift frames the lower face. This is all framing. And you probably know this basic concept, which is that we change from this inverted egg type shape. So talking about this, we start having to look at shaping of the face. And if we want this ideal, we usually talk about the OG curve, which is from the 3/4 view, which I think is very, very important. But you'll see my before and afters are principally from the frontal view, because that's how we relate to each other socially. So let's get back to this concept of facial framing and go into it a little bit more in depth. So for me, these three components are the areas that I'm fixated on in terms of facial shaping. And then the little X mark means is an area that I don't want to do because it violates the concept of filling in this area, except of course when it's needed. And I'll show you some before and afters when I do that in someone that's very gaunt or has had a facelift and they've been excavated in their lateral mandible. And sometimes you'll see in a before and after too, I use Botox or botulinum toxin to migrate that area in and to create a thinner face that looks better. And then the eye is just the upper and lower eyelids, but there's a lot of minutia that I'm going to explore in depth in this talk that I think is worth it. And tomorrow, I encourage you to come to my lecture where I'll be giving a very similar talk, so a little bit of redundancy. And then I'm going to talk about how I look at the marriage of fat transfer and fillers and how each technology is leveraged in my practice. And then just filling around the mouth. So those are the components. One of the things here, so this is just talking about just the temple. I think this is actually a little out of order. But the concept here is really understanding how to fill the face, is going up and shaping this face in a lateral perspective. And the reason for that is that it allows me to create an oval. And so for me, what creates that feeling that the face looks older is this irregular concavity of the lateral aspect of the face. And there's the shaping that I want to create. So if you think of the zygomatic arch as a break point or a middle convexity, I'm looking at the concavity above and the concavity below, and I want to create a nice shape. So every time I inject the patient, I inject from the side, and then I go to the front and look and see the transformation, because obviously if the 3/4 view looks good but the frontal view looks bad, you've got a problem. And I think as if you guys are mainly surgeons in here, which I think you are, the surgeons are so used to the lateral perspective, because that's how we do facelifts. It's even from a rhinoplasty, we're oftentimes standing on the side. So I encourage you, always as you inject, stop for a moment and look at calibrate yourself from the frontal view. Are you materially impacting the patient in a favorable way? Are the shadows that are being cast from the frontal view being improved. And a lot of times patients have a more limited budget. They only have 1 or 2 syringes you have to do. And what I do is a micro droplet approach. I'm filling a little bit, looking at that shadow. Is that good enough? Can I put more? Do I have to move over to somewhere else because I'm running out of product? So I always start with what is the budget, and I work backwards to figure out how my eye can make that face look as pretty as possible. And so one thing that I've really started to become wary of, both in fat transfer and fillers, and I'll be honest, particularly in fat, because the retention rate is so high in the anterior cheek, is that anterior cheek. And what's funny is most people that fill, they fill lips, folds, and cheeks. Those are 3 areas I usually don't fill. I'm usually focusing on the lateral face. I'm focusing around the eye and the mouth. The reason is that this is a dynamic issue. They look okay when they're not smiling, and when they smile, there's this excessive motion that causes bunching. It doesn't look balanced. So that's very, very important. So let's talk about the eye frame. I think what's so important is that a lot of women come to me, they're focused on their mouth. They think it's what makes them older. But I would contend that when we evaluate each other and we interact on a social, professional level, we're interacting on the eyes. If I have a conversation with you, 99% of the time, I'm looking at your eyes. So when a patient has a more limited budget, or when they ask where should I start, I usually help them understand, let's start with the eyes, because that's what's going to make that social professional impact. It's more complicated, it's more difficult, and I don't encourage you to start there if you're a novice, but it's an area that makes the biggest impact, and it takes least product to make that change. So if we talk about the eye, and we're looking at a frame to the face, it's a circle, right? But then we can actually take that concept and explode it a little bit into 2 asymmetric triangles. And this is something that we talk about, the long limb of the bottom area, which is really this bottom area here. We say that needs to be filled, tear trough, but there's this articulation out here that goes all the way along the edge. In fact, I would argue it's circumferential. We typically fill the outer brow. We've got to be very careful with this, because this can look too heavy like a Neanderthal. So one thing I'm obsessed with is this A-frame. What it does, why do I focus on this? If someone comes in for fillers, most of the times I just start with this little drop. Because if you think about it, when you start looking at a mature eye, it starts to look like it's sagging, right? Well, what is sagging? It's partial involution. So yes, you can fill the lateral brow highlight, but what it does is if you fill that inner brow, it starts to horizontalize the eye. It starts to create a horizontal aspect. So putting a little bit in that A-frame makes a huge difference. And the way that, a little pearl, the way I do it, I'll take an eyebrow pencil, I'll mark the A-frame dot. I'll go to the side, inject, I aim to the dot. Then I'll come back, look at the front view. If the dot if I miss something below the dot, I'll come back and fill below the dot. So it's a very quick way to do this. So I oftentimes don't even fill the lateral brow. And if I do fill the lateral brow, where I'm usually filling it is the transition point where the brow bone goes down into the lateral canthus, and I see this little brow bone edge. So think about filling bone transition points from bone to soft tissue. If you don't have enough product because of patient budget and you're trying to fill a whole area, don't do that. Look at where the bone highlight transitions to soft tissue. Just look at where the drop recess is. When you see that little recess, hit a drop in there and see if that transition's gone. When that transition is ameliorated, the patient looks better because you're trying to get bony configuration softened. So this is, again, going back to this view and then understanding that I want to fill this. I'm going to talk tomorrow about how I do it with fat, but for tonight it's just about fillers. So I'll come like this, right down to that A-frame. Occasionally I'll fill up here, occasionally I'll fill here, occasionally I'll fill into the canthus. The canthus is huge. I fill that whole frame. Come up here, come up here. This is really where a lot of the art goes, and I encourage you that is to focus on that area all the time, because it's so critical. And look at the temple, and when you look at the temple, this is interesting. You don't just fill the temple. You look at the conjoint tendon here, and sometimes this conjoint tendon, if you just fill that transition zone, it's enough. And you don't need to get the whole lateral recess. Sometimes the lateral recess is a problem because when you see them from the frontal view, you see this depression that bothers your eye. And I have a colleague in Canada I share a lot of ideas with. I innovate some things, tell it to him, he innovates things, and I'll give him credit for this. But he talks about, and it's made a big difference in my practice, is filling behind the hairline. Because the temple is a lateral extent that goes all the way out to the side. So when you're looking at it, don't fill the face, fill the head. And so if you can see that lateral depression going out and that oval, shoot out toward the hairline only if the person needs it, if it's bothering your aesthetic eye. And you're going to start training your eye to see this, and it takes, I guess 10,000 hours or whatever, but even if you start getting into the 50th hour, you start to see things. And when you see, you can innovate and think differently. Actually, the latest thing that I've been doing recently is this, which is when you fill the orbital rim, I've noticed that there's still this step off above it where they look empty going into the ciliary margin. And so what I'm doing now is I am taking a little bit of HA and I'm layering it really slowly because it can bunch. And you're going right up to the ciliary margin, and bam, that transformation is mind-blowing. When someone looks in their mirror, they can't, why do I look so much better? Because I've filled them from the edge of their orbital rim all the way to the ciliary margin. Now, you got to be careful. I don't do that with fat grafting, and I'll talk about that distinction. I think that's problematic. And this is just showing this more horizontal aspect when I fill it. This is just a lady that I filled right after, this is an image where I'm filling this area. This is showing how I approach this side, and this is showing the tear trough here, and this is that eyelid margin fill I was telling you about. And this is just, it's hard to see because the images are not that blown up, but this is just a lady that before fillers, some fillers, and I came back and filled a little bit close to the margin. It's hard to see this, but it's a safe procedure if you fill very, very slowly. Around the mouth, I oftentimes don't even fill the entire nasolabial groove. I usually just fill the recess right near the nose. And part of this is some of the ideas that Val Lambros has talked about in understanding how the loss of volume right here at the premaxilla can really change the way that our brain views aging. So instead of filling a fold, in which the fold is to me the least important thing I usually deal with in most cases, I'm looking at how the recess affects the face. And if you say, well, how does it affect the face? This is that synthetic, or not synthetic as in fake, but as in a cohesive, coherent model of how your brain views beauty. And I ask you to constantly start understanding beauty. The funniest movie I saw was this movie about men's clothing in Italy, and this older gentleman was teaching this Japanese apprentice how to make clothing. And he said, before you start making clothing, I advise you to go and learn how to drink coffee correctly or cappuccino and go to a museum. So if you don't start understanding art and beauty, don't just start injecting, because it is an art and it's passion, it's fun. It's not just filling a fold. If I just fill the fold all day, I'll probably kill myself. This is about designing a face, and that's what I want to excite you guys about. And then just filling the anterior chin in that whole recess of transition from the mandible up. So I've evolved from 27 gauges because they were very fine. I went to 22 gauges because I heard a lecture on this, but I found this to be a bit rough, and I saw some of the cannula marks coming through. 23 I moved to is better. Currently, my preferred is a 25 gauge. It seems to work well for me, and I like to liken this to like building a house. When you remodel a kitchen, all of a sudden the bathroom looks bad. And so when I'm designing, I'm always saving a little bit of product, because I wouldn't even notice sometimes part of the temple. I'll make the eye look better, and all of a sudden another part of the face looks off. So I've got to constantly save a little bit as I design. So we're almost finished with the talk here, but essentially, looking at all the zones of the face is how I encourage you. Don't look at the face as one area, but look at it as a composite of multiple zones. And if you do that, then as I was mentioning, you've got to have priorities, because people don't have an unlimited budget. You can't just fill 5, 10, 15 syringes, and you just can't do that. And you say, well, that's going to look overfilled. Not if you stay away from excessive lip and cheek. You won't overfill them. You can fill around the face, and you're going to be okay. So look at priorities. These are just random priorities. They're not random, but these are just thought processes as I start to see the face. And so if I have 12 areas to fill, let's say I've got one syringe, and this is obviously arbitrary. It's meant to have you think in a larger fashion. And this is just hitting different priorities. I may not fill every priority to the level I want, but I'm getting the areas that I think will aesthetically impact the patient. And I'm sort of a pain in the butt, because when patients come to see me, I hear their input, but I really advise them because they don't know what they want. They want to look better. I guide them away from craziness and move them to something that works. So I believe it's an asymptote. In other words, I always tell patients, look, you're never going to get anything perfect. If you want they tell me, Dr. Lamb, you filled my temple 4 times. Are you screwed up? I paid for this 4 times. I said, look, I filled it partially. It's going to go down a little bit. I'm constantly working against that. And so I found what's really interesting, I've moved really to a profile of all HAs because I found the safety profile higher, and I found that these things last years. Once you start building that, it starts to last longer and longer. So it's like taking 2 steps forward and 1 step back. I use a lot of vibrational energy, but to be honest with you, the vibration only affords about 10% improvement in pain or discomfort. The number one reason patients don't come back to you is not a poor result, is pain. And so what I do is I do a lot of pinching, a lot of vibration with my fingers, but I always have my needle resting on my non-dominant hand so you don't stick yourself. And so my vibration affords about 90% pain reduction. About the remaining 10% is going to be from my staff helping me. This is my staff at 43 versus 46. This is an example of really lateralizing the face. I'm sorry this lady has a little bit more makeup on. I didn't do her lips on the left. But this is showing you a face that needs that ovalization, which to me is very, very important. You can look at the lateral face. It looks like she needs a blepharoplasty. She definitely needs a facelift, but this is all done with fillers and some neuromodulators. So you can if you think of the brow as a deflation, you can improve that. This is a lady from 36 to 42, and this is 30, 40 syringes done over that period of time. But it builds and it lasts and it looks better. This is also a lady you saw earlier, about 30 syringes in the face, and it seems like, my God, you must be insane. But no, if you do it well, they're not going to look overdone. This lady at 53 with overdone eyes, etc., and this is 60 on the right. So it's slowly built with multiple syringes over time. This is a lady that had, she actually gained 10 pounds on the right, but she had Botox jaw slimming, and then a little bit of fillers around the eyes. This is only one session, so she's not as good as the ones that I've shown you that I've done multiple sessions on. But this, because it always takes 2 steps forward, 1 step back, but she looks a little slimmer, so that's the design. This is a lady that I've combined rhinoplasty, facelift, eyelid work, all the big surgeries, and fat transfer, and laser. But in addition to that, I also did some fillers. So to me, you really need to polish. I believe as a surgeon, the combination of surgery and non-surgery can be an amazing thing. You have to think as a surgeon and a non-surgeon if possible. So I encourage you when you leave here is to think not only in terms of a mechanical, technical approach, which is so critical, but also from an artistic perspective. Thank you.